Hi everyone, this is Tim, your Block 3 lecture instructor, and because of the possible or potential cyber attack on Maricopa, we are no longer in school for this week. So I decided to actually do your orientation as a voiceover. That way you have a chance to look at it, get some codes, and start on some things that we have to do. Um, Nothing's really being changed. I know that today would have been orientation and math, and then tomorrow would have been neuro. But all we're really doing is just moving everything to next week. I am still working on the calendar, so the test dates may actually change, but for the most part, nothing else is changing as far as content. And like I said, we're really just moving everything by 1 week. I also figured that if I did this orientation PowerPoint today and you listen to it this week and get all your codes, then next Monday, all we really have is med math. And by then, you should hopefully everything will be up and the packets will be available to you and you can work on them. And that will be pretty quick. And I think that's pretty much about it. So think of this week as being more of an extended spring break, relax, just kind of work on things as your leisure. And I'm pretty laid back, so don't get all stressed out about a lot of stuff. So, all right, so Block 3 Spring 2021 orientation. Let's see here. Class and lab hours. Class is, or lecture is on Mondays and Tuesdays. So for those of you who have lecture from 7 to 9, that is Monday and Tuesday. And for those of you who have lecture from 9 to 11, those are also Monday and Tuesday. I do not do lab on Mondays because usually OB takes the lab rooms and it's easier for me to do them on Tuesday because they don't. So lab, I know that you guys have signed up through the Sign Up Genius as far as your specific times. To prepare for lab, once Canvas comes back up, there is an actual lab section. Basically, you're going to watch some sort of video on what we're doing in lab. So whether it's an NG tube, you'll watch a video on how to do it, and then there's probably some sort of article you can read, and then there's some sort of quick 5 to 10 question quiz that are not worth any points, but it's really just to kind of test your knowledge. And then when you guys come to lab is about 45 minutes long, so it's really just you preparing for lab, and then we really physically show you how to do it, and then you practice it, and then you're done. And that's due to COVID and the pandemic from last year. So it actually seems to work pretty well. It kind of gets you guys in and out without having to spend half a day trying to work on something that really only takes about an hour. So I actually think that it's worked to our benefit on saving time. So let's see here. Lab is not on Mondays; it's only on Tuesdays. We do want you to wear your Maricopa scrubs, and you must attend. Lecture, if you want to come to it, great. If you don't, you don't. But lecture is more of that explaining the PowerPoints, the voiceovers, answering all your questions. I really do bring the lecture to life using a virtual whiteboard, and I use the nursing process, and I'll go over that as we get further into this PowerPoint. So, but for lab, you have to attend because it's considered part of your hours for the board because it proves to them that you have actually practiced the skills in a lab setting. All right, so my weekly schedule and office hours. Again, classes Mondays and Tuesdays. Lab is on Tuesday afternoons after lecture. Clinical replacement and simulation. So to explain how this really works, I know you all will have a clinical day. It is a 12-hour day at one of the Banner hospitals, but that's not enough hours. So what I have done is created a clinical replacement. And basically what you're going to do is you will have a lecture instructor or a lab instructor or a clinical instructor or whoever you want to talk about. It's either myself, Darren, or Cindy. And the three of us will be with a group, and it's roughly from 7 in the morning until 7 in the evening. Now, it is not 12 hours long. It's really probably going to be a half a day. But do not plan for working in the afternoon. Don't plan for not having a babysitter. Plan on being there for 12 hours because if it does extend at some point longer than what we had expected for whatever reason, then you're not stuck. Clinical replacement and clinical must also be attended because it's part of your hours for the board for block 3. So I just basically leave it as being every Wednesday from 7 a.m. until roughly 7 p.m. In the afternoon or evening. And we do case studies, we do med math, we do medications, we do all kinds of activities. And at some point, they're kind of, I think they're worth it. I mean, at one point, I was kind of like, oh, okay, this is busy work. And I don't like you guys doing busy work because that's time that you could be studying instead of wasting your time on something that either is boring or stupid, or you're not really getting anything out of it. So, but I think the case studies and the medication sheets and VSIMs and the stuff that we are doing, they're to a degree, I think beneficial, and they actually do kind of work out. So as far as office hours, I am always available by WebEx. So if you guys have any questions, or if you want to hop online, or if you want to, ask me anything, usually my laptop's on. I'm usually sitting in front of it. Due to COVID, we're pretty much living at home. So, but if you also send me either an email or a message through Canvas, I usually respond to it within probably a good hour. If I haven't responded to it, I'm probably working on something that you all have asked the same question, and I really sent out one um, email or message to all of you, so that way I'm not having to send 50 individual ones. So, but when it says appointment, send me a message saying, hey, can we meet? That's pretty much your appointment. So. All right, so let's see here. How I teach. I went to Gateway Community College. I went to a really good school. I really liked it. But I sat there in class for 3 hours a day, and we did nothing but PowerPoint, and that to me was the most god awful boring thing I have ever done in my entire life. So I swore that when I became an instructor, that I would not, do PowerPoint in the classroom setting because I mean, you can sit at home in your underwear and do a PowerPoint. You all have read, you all can read, you all can do these things at home. So why come to class? What I usually do is I do what we call the whiteboard, and I actually take the information that you've learned from your book or the PowerPoint or the voiceovers and kind of bring it to life using the whiteboard. And again, I'll go over that in a second. But I do that because, like I said, PowerPoint is just boring. I also teach by critical thinking. Critical thinking is not saving grandma's life. It is not a life and death moment and decision making. Critical thinking is really just being a couple steps ahead of yourself, going, if I do this, what do I really expect to happen? If I do this and this happens, do I have a plan B? If I do this and something bad happens, or if there's a potential, am I prepared to be able to fix that? So critical thinking isn't just walking into the room and grandma's blue and putting oxygen on her and making her better. It's really more of walking in the room. I have to give you this. There's a potential for this problem. Am I aware of it? Am I ready for it? Am I able to actually, fix it if something happens? Or, I give Lasix to grandma because she has CHF, and I know that potentially her potassium will go in, from 3.5 down to 3.2 or 3.1 or 3.0, and I know that I'll probably have to get some potassium. Do I have potassium ordered? No, there's no potassium ordered. Maybe I should call a doctor. Maybe I should actually ask them, hey, I'm going to give Lasix. Can I have a protocol for potassium replacement? So that way, if this does happen, then I know that I actually can fix it. That's critical thinking. It's really just thinking ahead and just knowing what to do. It's making the most logical decision at the time with the information that you're given. I've been in several situations where after the fact, I'm like, oh my gosh, I should have done this. Well, that's great after the fact, but at the time, this is the information I was given. This is the decision that I made based on that information, and this is what I had at the moment. Taking 10, 15 hour, half a day later going, oh man, I really should have done that. That doesn't do you any good. You did the best that you can at that moment. And I really teach that to you guys. So that's what I think as far as critical thinking. As far as nursing is completely situational. For those of you who are black and white thinkers, and I'm not, trying to make fun or point you out or anything like that, but nursing is very gray. Grandma with CHF with a urinary tract infection may present one way, and we may do certain things for her, but then another grandma with CHF and a urinary tract infection may have something different, different meds, different problems, different situations, different outcomes. So you can't really just say, okay, well, I see this, I'm going to do this, and this is the outcome. It's, I saw this for this patient, I'm going to do this to fix that problem, and this is my goal, or my evaluation. Did it really work? But applying that to every patient is insane because everybody's different, everybody reacts different, every patient's situation is different. So when you do your studying, I want you to make your list. Here's the things I see for this disease process. Here's the typical things as far as interventions that we would do to fix these problems. Here's the diagnostics that we would do to prove what we either see or prove that we're going to do something, or prove it to us why we should be fixing it. But the evaluation is, did it work for this grandma? Did it work for this grandma? It may work for one, may not work for the other, and that's where your critical thinking is. Okay, so with this patient, I think this is going to happen. With this patient, this may or may not happen. So nursing is completely situational. And again, those of you who are very black and white of, I saw this, I do this, and this is what's going to happen, that doesn't really work, just because of the fact that, like I said, everybody's different and different outcomes are just going to happen. I usually kind of pinpoint you from, usually at least first, second, or third lecture. And my goal as an instructor is not so much to, make fun or bully you into, oh my gosh, you're the black and white thinker, but it's more of, I need to teach you how to think differently. Just because that's my job. My job is to teach you how to think like a nurse, to be a good nurse. And so you get out there, you're like, okay, he taught us this. This is what we should be doing. And part of that is actually taking those black and white thinkers and turn you more gray and just realizing that different things will actually happen. All right, so practical nursing, I will tell you a million times, I am the laziest and the dumbest nurse in the entire world. Technically, I'm not. But the reason why I tell you this is because I think very logically. I'm very practical thinking. I try to be the most efficient. I try to be the most organized. And that's what I try to teach you guys. When I ask a question and you either go into a very in-depth, chemical composition or molecular structure, nobody cares. And the reason why I say this is because as a bedside nurse, I walk into the room, I see this. What am I going to actually do to fix that? If I do this and it actually takes care of, let's say, 2 or 3 different problems, then great. I get to be lazy because I only had to do one intervention to fix a whole bunch of other problems. Don't be the nurse where you take one thing to actually fix a problem and create 5 other things, because that turns into more work and more problems and having to be behind as opposed to being proactive enough. So I think very logically, if I see this and I do this, this is what I expect to happen. I will go into some depth, and there's certain things that is going to be a little more thought-provoking or a little bit more in depth, and that's fine. That's just based on the disease process or labs or the way the patient presents themselves. But for the most part, keep it really simple. Because that's just the way it really is. We're not there to diagnose them. We're not there to actually fix them. If it's a disease process like a UTI, yeah, we can fix them. Give grandma some antibiotics and make her better, and then she goes home. I can't fix a patient with a chronic disease process that cannot be fixed. Cancer, endocrine diseases, those are things that they're there for us to fix the symptoms, make them better, and send them on their way, and they can live with the chronic disease. It's about managing it and staying out of the hospital and making them better so they're not coming to us with severe dehydration or electrolyte imbalances or pain management. Those are things that we'll fix, but we're really not going to be able to fix their chronic diseases. So again, practical nursing is really just thinking logically, and what can I fix? What can I not fix? What can I do to make grandma better? What can I do to make grandma well enough for her to go home, but home as a baseline? If they came in with cancer, I'm not going to cure them of cancer. If they come in with alcoholism, I cannot make them not an alcoholic or a drug addict. These are things that those are things that are out of our control, or those are long-term things that will actually have to happen outside of the hospital. All right, so one day we will work next to each other. I know that in the past, and in fact, when I went to nursing school, I heard this all the time. One day you'll take care of me, and I want you, I want you to be a good nurse. I am 47 years old. I still work bedside. I work for Honor Health. I float between Johnson & Lincoln and Osborne. I've worked for them for almost 20 years. I went from being an aide and a phlebotomist to an LPN to an RN. I still practice and I still work at the bedside. I actually work with some of you, whether you're an aide or I've worked with students that I've had before that have graduated, and we work next to each other. And it's actually a pretty fun, experience in the sense of, you get to know me, you learn how to think like a nurse. I've taught you how to do things in nursing school, and then all of a sudden one day we're sitting next to each other and we're talking about our patients and we're talking about how to take care of them and stuff. So it's actually a pretty interesting experience. Way back when, my Block 3 instructor at Gateway, she still worked bedside at Honor Health, and I graduated, and there was times we worked together, and so it's kind of fun. But I want to teach you how to think like a nurse because one day when you graduate, we'll work next to each other, and I want to give you the tools to be a good nurse. So when we work together, I can be proud and say, "Hey, that's someone I actually taught, and I know what I taught you, and I know that I taught you to be the most competent person that you actually can be." So, like I said, I'm 47, and I don't plan on dying anytime soon. So, by the time you graduate, I, you know, hopefully with luck, I won't be sick, and you won't have to take care of me. All right. So as far as lecture voiceovers, the PowerPoints, things like that, you have all the tools for you. I want you to read your book. I put on here chapter by chapter, page by page, paragraph by paragraph, because that's what you're going to do. You're going to basically highlight things that are important, and next thing you know, you look at every page and they're all highlighted. I really want you to use the book as a guide. I don't teach patho very well or at all. Most of you have never had pathos, so use the chapters that are in your book. Let's say example for neuro. If you go to the neuro section of your book, the first couple of chapters are the patho of the brain and what it does, and the anatomy and physiology and all the other stuff. If you don't have a good background in it, then learn from that. Read it, understand it, and make sure that you know what to do with that information. For those of you who have had patho or understand it, skip it, or you can skim through it and just kind of refresh your memory on what's actually in it. When it comes to the actual chapters, I don't specifically sign pages, because if I sign just a page or two or three or where the diseases I'm teaching you, you'll just go to them, you'll skip everything else. One, I can't teach you everything that I know, it's impossible. Two, yes, I will test you on things that are potentially in those chapters, more so on what the PowerPoints and the voiceovers are. But in the same sense, too, one day you may take care of a patient that has Bell's palsy. No, it's not something that I actually have to teach you. It's not something that's in the PowerPoint or the voiceovers, but it's in the book. And one day, if you take care of the Bell's palsy patient, you can't say, well, I didn't learn that in nursing school because we didn't have to read it. And then your patient's sitting there going, okay, well, what are you going to do? And you're like, I don't know. I'll have to look a lot of stuff up. So I really just have you read the chapters on a whole based on the system, because it's good information. I want you to know it. I want you to learn it. And then it really comes down to whether or not you're being tested. So if you ever ask me, what's on the test, or do we need to know to do, to study it? I'm going to tell you yes, because the fact that yes, you should know it. Yes, it is fair game. Yes, it's in the chapters. But in the same sense, I really kind of narrow things down based on the PowerPoint and the voiceovers. So read the book, understand the stuff, make your concept maps. It's probably the easiest and best way to study, because that's how I teach and that's how I think, and kind of go from there. The PowerPoint, print them out, make notes, use them for lecture, use them for your studying. The PowerPoint voiceovers, that truly is your lecture. So for those of you who are kind of like, oh, I've never had a lecture. Well, you have. The PowerPoints are your lecture. The voiceovers is literally me speaking and telling you what I want you to know. The lecture on Mondays and Tuesdays, that's me really kind of going back over all that stuff, but in a different way, and teaching you a different thought process live. So when it comes to your quizzes, which we'll go over and stuff, you have technically had lecture because of the voiceovers, and they're all found on YouTube, and they're all there, and I've done a million of them because I taught block 1 and block 2. So you really just have to be able to search me by name and you'll find them all, and they're all there. So all right, so the lecture is, like I said, is at Pi. It's the whiteboard, and so let's see here. see if I can find my whiteboard. So here's the whiteboard. I have a laptop that's touchscreen. There's an app that allows me to create a whiteboard, and this is basically how I teach when you guys come to class on Mondays and Tuesdays. I'm going to, ask you. Let's say it's, Tuesday and we're doing neuro. I'll ask you. So, Susie, tell me about what you know about Parkinson's disease. And you're going to go, well, Parkinson's disease is, based on this neurological process, and here's what the patient exhibits, and that's your assessment. Standing at the doorway, what do I see from my patient? And you're going to go, well, I'm going to see some tremors, and I'm going to see some, mask-like face, and I'm going to see them walk, and it's going to be more of a shuffling gait. Those are things that you see. That's your assessment. Never, ever, 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 ever tell me that part of your assessment is looking at, their H&H or the sodium level or the potassium level. That's not an assessment. That's a diagnostic tool to tell you what is wrong inside the body, things I can't actually see. So your assessment is things that you see at the doorway. Now, I've had some students be like, well, you can listen to the heart and the lungs and bowel sounds, things like that. Yes, I technically know that that is not at their doorway, but I'm trying to get you away from a computer and standing in the room. What do you see? Putting your stethoscope on your patient, what do you actually hear? That's an assessment. Symptoms that you see and hear and you're able to observe, those are your assessments. The interventions are things that you actually do to fix what you see as a problem. Your patient is having Parkinson's problems. They're there because they're, let's say that their levodopa-carbidopa isn't working well enough, and they're having, much more tremors than they were having before. Well, the doctor increased their actual levodopa-carbidopa by dosage, and your intervention is to give them a pill that has more of it in it. So I saw that they actually had increased tremors. My intervention is to give them levodopa-carbidopa. The evaluation is whether it worked. It's really that simple. I can even make it simpler than that. I know that nurses will tell you, and you probably either have heard or haven't heard based on clinicals, that we don't use nursing diagnoses anymore. And it's true. We really don't. I mean, I go to work, I do my job. Yes, there's parts of the charting, and they'll say, okay, the nursing diagnosis, we pick them, we click on it, we just skip it, and we're done. But in the same sense, too, we also have constant nursing diagnoses in our head. I work ortho, and I work tele a lot. If I walk into a patient who's had, let's say, some sort of accident and had a fracture, walk in the room, are you having any pain? Yeah, I'm having a little bit of pain. Okay, on a scale of 1 to 10, what is it? And you're like, oh, it's about maybe, let's say, 7 or 8. Great, let me give you something for pain. My assessment was, are you having pain? They told me they were having pain. I used a scale. They told me what it was. That was enough for me to give them pain medication. The intervention is I give them 2 Percocet. Give it about a half hour, 45 minutes later, did it work? If it did, I did my evaluation, it worked, there's nothing else to do. If I walk in and do a pain assessment, they tell me it's a 7, I give them 2 Percocet, I go in a half hour, 45 minutes later, reevaluate whether what I saw was taken care of by what I did, and they say, no, it didn't really touch it at all, then I need to do something different. That's your plan B. Your critical thinking was, I saw that they have pain, I want to give them 2 Percocet. Let's say that you walk into grandma's room. She fell and broke her hip. She's 80 years old. I can give her anything up from 2 milligrams of morphine, 4 milligrams of morphine, or 6 milligrams of morphine. By critical thinking is thinking grandma who's soaking wet, 80 pounds, who's 5 foot nothing, the skinny little thing laying in bed with a broken hip, I don't need to give her 6 milligrams of morphine. My critical thinking is, how many respirations does she have? Can she handle that much? What will happen if I actually give her too much? So the critical thinking is just thinking ahead in the process of what would I do and what do I expect to happen. Maybe start off with 2. Did it work? No. Give her 2 more. Did that work? Yes, it worked great. And she's breathing well. She's alert and oriented. The pain's controlled. That's critical thinking. That's the nursing process. That's thinking like a nurse. So that's how this works in lecture on Mondays and Tuesdays. I go through the disease processes. You guys tell me what you see, things that you would do to fix those problems, diagnostic studies that we would actually do to either prove that we're doing the right thing or prove that we need to do something, and the evaluation is whether those things actually worked. Education is based on, grandma has a UTI. What do I need to teach her so that way she stays out of the hospital? If I fix her from having a UTI and it's because of the fact that she's wearing a brief and she's not cleaning herself well enough, then I need to teach her that. If I don't, she's going to come back with another UTI because no one taught her how to wipe well. So that's the education part of that. All right, so let's see here. All right, so that's how the whiteboard works. That's how lecture works. All right, so I've talked about this to death. So lecture is ADPI. It's the nursing process. What do I see at the doorway? That's your assessment. What do I actually, use as a tool to diagnose or a diagnostic tool to prove what I need to do or fix? The diagnosis is something that the actual doctor gives them. You can walk into a room, and I don't need to even know what the problem of the patient is. I walked into patients' rooms that I'm not even taking care of, and I'm like, you seem a little confused. I don't know you. You seem a little off. You need to go to the bathroom. Can you go to the bathroom? Can you walk? We walk them to the bathroom. They get done. Talk to the nurse. Hey, grandma seems a little confused. Is that baseline for her? Oh, yeah, that's okay. So that's fine. I don't need to know anything about her. I just need to know information on what to do at the moment that I need to help them. So we're not worried about diagnoses. We're worried more about what I need to do to actually fix grandma. So whether she's blue, put oxygen. I've walked into rooms where they're not even mine, and I'm like, grandma, you're blue, and your oxygenation's at like 75. I think I need to put oxygen on you. I don't need to know why she's there. I just need to actually fix her. That's the plan. The interventions are things that you're doing to fix the problems. And again, you evaluate whether the intervention worked and you educate your patients so that way they don't come back, or, that they are either better or we've done something to make sure that they're able to stay home. All right, so we talked about the whiteboard. It's interactive. I do ask you questions for the 2 hours that we're together. You will actually log on through the through your Maricopa email calendar. You have all received an invite for a lecture. You click on the link and it pops you into the class. I do it that way because I found that big blue button doesn't work real well. It's kind of choppy and the quality is not that great. But WebEx actually works pretty well. I ask that you all put your cameras on. That way I can see your face. It's interactive. I mean, even though we're not actually in the classroom, I still want to see your face. I want you to see my face. I still want to be able to ask questions, find answers. If you know anybody who's had me before the flip, they'll tell you I'm asking you to come to class prepared, and I'm leading pretty much essentially a study group. I ask you questions, you give me answers. You don't understand, I clarify things. You may ask me questions that I may not know, and I'll look things up and I'll actually get back to you and give you answers. So this is really more of, you've read the book, you've done the PowerPoint, you've done the voiceovers. Now you're coming to class, and I'm driving you down a path to direct your learning and your studying. I used to believe that actually, sitting in front of you guys and telling you how I think like a nurse and what I do at my job was enough. And I used to believe that I could stand up there and regurgitate what I've done for the last 20 years and you would learn. And that's not really the case. Learning is actually you reading the book, me steering you down the right path as far as how to study or what to think or what to learn, and making sure that you understand it. That's teaching, and that's what I want you to get from me. I do not teach to the test. I don't teach to NCLEX. I don't teach you how to take the NCLEX. I'm teaching you how to think like a nurse. When you take the NCLEX, you're thinking like a nurse going, okay, so it asked me this. What would I do? What would I see? What diagnostic tools would I use as my in my favor? Those are the things that you will learn how to do and apply them to the NCLEX and for you to pass them. Me teaching you how to take the NCLEX, that's a lot of time that I don't have, and that's also a lot of time that you could be either studying and that you don't have either. So I'm really teaching you how to think like a nurse, so that way you are prepared for Block 4. And let me tell you, Sarah, who is your Block 4 instructor, she also still works bedside. I'm teaching you how to think like a nurse. She really just takes, she gets you and she teaches you the same way I do. So I'm preparing you for Block 4. And like I said, by the time you graduate, you're really prepared to actually take the NCLEX and you will all pass them. All right, so I put this slide up here because during lecture, I'm going to ask you questions that you will be like, I have no idea what the heck he's even talking about. I want you to learn how to look stuff up. If I ask you a question that you don't know, then use Google, use your book, use drugs.com, use whatever tool that you would like to use to quickly look something up to be able to say, oh, I see. Okay, so here's what I would do. And I'm like, great. And the reason why is because this is a life and this is a professional tool. I do not know everything. I do not know every med, and I do not know every disease process or every disease for that matter. But when a patient asks me questions, I pull out my phone. You all have a phone. We all have a phone. We're all connected to a phone. We're all connected to a mini computer. So I look stuff up. Oh, you're on this med? And they're like, what am I taking that for? I really don't know, but let me look it up. I Google it. Oh, it tells me this. Oh, that makes sense. Okay, now I get it. And then I tell them why they're taking it, what they're taking, and then I learn the side effects and what I'm expecting it for to work. Now, granted, those are things that you would probably want to know and need to know before you walk into the room to give grandma her med, but sometimes you're busy. Sometimes there's like, oh, I think you're taking this because of this, and then we get in there and she's like, I don't have that. And I'm like, oh, but you do have this, and this med actually does work for that. So those are the things that I'm trying to teach you that, like I said, we don't have all the answers, we don't know everything, but I want you to learn the tools that you like. So by the time you graduate and become a nurse, then you actually go, you know what, nursing school, I really like this website. Drugs.com is the simplest, easiest medication website I have ever used in my entire life. It's quick, it's simple, it tells me everything that I need to know, and I still use it. So these are the things I'm trying to teach you, so that way. So like I said, when I'm in class and I ask you a question, don't be afraid to be like, oh my God, I have no idea what he's talking about. Well, then let me walk you through it. Usually you know the answer. It's just a matter of me pulling it out of you, or at least getting you down the path to go, oh, okay, I get it now. It's because of this, this, and this. So again, usually you have the answers. It's just a matter of me kind of steering you down the right path. All right, so case studies. The case studies are usually in the clinical replacement. We used to do them in lecture when we had time and we actually were live. But because of COVID and the lack of clinicals, we have moved the case studies into clinical replacement on Wednesdays. So there's usually a case study, for every system that we actually learn. I like the case studies. I got them from a book. There are no actual right answers to them. It's more of us reading through the scenario, and then they present questions, and then we talk about them and be able to. I like it because there's some students, and I'll tell you, not everybody loves my style of teaching, and that's okay. But the majority of you will actually start to appreciate it. And let me tell you, I work next to nurses that I used to teach, and when they graduated, I asked them honestly, like, "Hey, did you like the way I taught you?" And there's nothing to lose or gain by lying to me. So a lot of times they'll tell me, I liked this, but I absolutely hated this. Great, this is your class. Tell me what you like and what you don't. So I don't want you wasting your time. I don't want 27 students to go, yeah, this sounds really great. And then you're all online going, God, he sucks. Tell me what you want that works better and what works and what doesn't. Again, my lecture does not fit everybody, but it fits the majority of you. And those of you who don't like it, can't get it, don't like it as far as the way I teach, or can't get you to think that way, I do other things. The case studies will help you a lot. You having Darren and Cindy, which are bedside nurses, and getting a different perspective, that's going to help. There's a lot of different things that I do. So the case studies are kind of an extension of lecture. They're presenting you with a scenario that gets you to think a little bit differently. So I do like them. But again, it's bringing the book, and it's bringing the PowerPoint, and bringing the voiceovers and my lectures to life. All right, so NCLEX questions. If you're on campus, the NCLEX 4000 is on every computer. I know some of you have UWorld. I love UWorld. I think UWorld is actually a really, really good platform for NCLEX style questions. Evolve is another one. There's books out there. There's other programs. I don't care what you use. I want you to do NCLEX questions every night. Do not study by it. Do not read the question and go, okay, I got that wrong, but here's the rationale. Okay, so apply that rationale to this patient. That doesn't work. What I want you to do is I want you to use your NCLEX questions for bathroom breathing. I want you to read the book. I want you to do the PowerPoint. I want you to do the voiceovers. I want you to do a lecture. I want you to use the NCLEX questions to be able to test your knowledge. They also teach you how to read like a nurse, which is essentially what the NCLEX is. You're the nurse taking care of so-and-so, and you walk into the room, and this is what you see. What will you do next? That's an NCLEX question, and it's that simple. So when you read NCLEX questions, whether it's 25 or 50 a night, use it with testing your knowledge. Did you understand what they were asking you? Did you understand the material in the book? Did you understand what I was talking about? And this is why. And you go, oh, okay, that makes sense. And now you're just changing the way you think. Do not memorize the answer going, okay, so according to this, every GI bleed, I apply this to that, because that's not the case. Every patient's different. Every question is different. Whether it's them asking you for an assessment or an intervention or a diagnostic tool, they will change something that does not fit every patient. And that's why, for those of you who are black and white, you can't apply it to every patient. You can't apply that rationale to every person who has that disease process, because something will always change. But the more NCLEX questions you do, the more you practice, the more you understand things, the more you start to read like a nurse, and that's truly the NCLEX. So how do you get your points? Let me have this. So you also find in lecture that I'm a soda connoisseur. So between Pepsi and Dr. Pepper, I drink a lot of soda, and usually it's more for actually because my throat gets dry. But it's 9 o'clock in the morning. You're like, oh my God, he's pounding down Mountain Dews, and it's like, well, not because of the caffeine, it's more because of the carbonation. So a little tidbit from me to you. All right, so how you get your points? Pass point. I had received an email today from someone saying, hey, if we're going to be off for a whole week, can we at least have the pass point code so that way you can at least start on your pass point? And that answer is yes. So pass point. You are in group A, B, C, and there was an X, but I did away with it because you only have 3 instructors. So those of you who were in X, you are now in one of those groups. Anyways, the code for pass point is 4AA23BED. If you go to PassPoint, punch in that code, add the class, you actually have, and I don't think the actual dates really change, because if you're starting them now, you have a whole week to actually do this. And the April 6th due date and the May 3rd due date were, I believe, test days. Now, those obviously will change, but for the most part, we'll stick to the pass point being on the April 6th and the May 3rd, just because of the fact that they're NCLEX-based questions. They're coming from Lippincott. I found that Block 1 and Block 2, which I used to teach, I heard over and over and over and over and over again that you guys hated Prep U. I find that it probably was good at the time because of it being more knowledge-based, and it was trying to test whether or not you understood and if you had the answers. PassPoint is more NCLEX based, and it's more NCLEX style. And so that's why I use it. I'm now finding out that some of you don't like it, and for the most part, I might have to look into another program or something different, just based on, like I said, I don't want you wasting your time doing busy BS. I want you to actually get something out of it. But for right now, this is what we have. So we will say that it's due at 8 o'clock on either April 6th or May 3rd. You will find that April 6th, that due date and what is due for that due date, there's a lot of questions. You have to get a mastery level of 5. I set it up that way because the questions are harder. I want you to think deeper. I want you to, we're no longer in Block 1 and Block 2. You're not going to apply, grandma with a UTI, here's what I see, here's what I do, and here's diagnostic tools. We're going to apply what you learned in Block 1 and Block 2. I taught those classes. I know what you were taught, and my background is cardiology. So I know in Block 2 you learned CHF, I know you learned AFib, I know that you learned somewhat diabetes. We're going to apply those things to these patients. You're not taking care of grandma with a UTI. She's 80, for God's sakes. She has a lot of other problems. Those other problems will change your interventions. Grandma with COPD, she's going to be dehydrated, or I'm sorry, grandma with a UTI is going to be dehydrated because she's peed herself all week long, because that's one of the symptoms of having UTI. Grandma also took her Lasix because she has CHF, because she wants to make sure that she, keeps the water off so that way she doesn't have the peripheral edema, and you want to make sure that there's not water on the heart. The problem is that grandma didn't realize that by her peeing every hour from the UTI and still taking her Lasix, which makes her also pull all that fluid off, it's going to make her severely dehydrated. I'm going to have to give her normal saline or half normal saline to hydrate her, but I also have to keep in mind that I can't run that too fast, because that grandma who has a UTI and CHF, that fluid's going to go somewhere, and running it too fast is going to cause other problems. So that's what Block 3 is about. It's applying those diseases you learn in those other classes, applying it to the diseases we're learning now, and that's more in depth. Block 4 is going to get more in depth than that. I will tell you, Block 3 is hard. There's a lot of diseases, there's a lot of symptoms in a short amount of time, and we're also applying the things you learned before to these disease processes. You all will do fine, but I want you to keep in mind, studying for 60 hours, getting a B or a C on a test is okay. I know the goal is to get an A. I know you want to do as best as you possibly can, and I want you to, but don't concentrate on the grade. Concentrate on passing. Concentrate on learning. Concentrate on, getting the information and understanding what I'm teaching you, how to think like a nurse. That's the grade. So that's what PassPoint does. It's actually to get you to think like that nurse and to be able to get a little more in depth and to think like a nurse and to be able to be competent. So the first pass point that's due on April 6th, there's a lot of questions. You have to have a mastery level of 5. Do not wait until the 5th of April to say, I'm going to sit down and do pass point. You're going to sit there for 12 hours and you may or may not even complete it. So do a little bit at a time, do a little bit throughout the week, get them done as fast as possible, hit that 5 mastery level and be done. And I say this because I have had patients or students have waited until the day before and they're like, I never finished. Well, you weren't going to. It's all based on whether or not you know the information or not. If you know the questions, you know the answers, you'll breeze through and hit your mastery level much quicker. If you go through and you don't know a lot of this stuff, it's going to keep giving you questions until you hit that level. So it's based on how knowledgeable you are. We'll say that they're still due at 8, the April 6th and the May 3rd. They are worth 25 points, but they're non-proctored. What that means is that you get the 76 in class, I add all the non-proctored points to it. That determines what grade that you have in the class at the end of the semester. I will tell you, I've had students not do this because they didn't think that it was worth it. And if you don't want to do it, don't. The problem is, though, is that because they got all the way done with the semester, they got a 76 or higher in the class, but they didn't do the non-proctored assignments, and 25 points is a lot, and it actually dropped them to a 75, and they didn't pass. I don't know what to tell you. So again, this is something that's to be able to help facilitate your learning, to give you a different way to actually think or a different tool to be better. Just do it. It's going to help you in the long run. All right, so quizzes. There is usually one a week. They are from the reading, the PowerPoint, the voiceovers. I did have them on Sunday evenings because I found that most of you who either work or have kid problems, or I don't want to say kid problems, don't have a babysitter, found that Sunday night when everybody was done and in bed and you were able to sit down and do it, it actually worked out. But I also found that Mondays actually work better too. So what I've decided to do is your quizzes will follow the lecture on Mondays. So every Monday, usually there's a quiz. When I finally get done with the calendar for the rest of the semester, because we got shifted by a week. Usually every Monday there's a quiz and it's from 11:30 to 12. It could either be through ExamSoft or Exemplify, or it could be a Word document. The Exemplify and the ExamSoft, those quizzes are 10 questions and they're NCLEX questions. Basically, you read it, you answer it, you turn it in, you're done, and you get the points. With the Word document, that's more of the nursing process. I give you a document that actually says, okay, so here is the disease process that I picked. I want you to give me things that you would see in this disease process. I want you to give me a couple interventions of what you would do in this disease process. Here's diagnostic tools. What would you use? What labs would you look at? And then as far as evaluation education. So it's a fill-in document, but it gets you thinking outside the box. It's not black and white. It's not cut and dry. There's a million things that you can tell me, and I can usually figure out your train of thought. So I like the Word document because it gives me a way of showing me how you actually think, and you get points based on that. They are 7.5 points. They are proctored. So if you don't do them, it's a 0, and that will drop your proctored point. If you do them, usually you get like A's and B's on the quizzes. So I do them because they're meant to bring your grade up, and then the test themselves is what determines how well you're truly going to do. But the quizzes also test your knowledge and make sure that it tells me whether or not you understand the material. All right, so for tests, there are going to be two. Again, I have to do the calendars and determine what days they're actually going to be on, but they are going to be on Tuesdays. They're always on Tuesdays because it's just easier that way. They are 60 points apiece, which means there's 60 questions apiece. 50 of them, roughly 50 of the points or the questions are actual NCLEX questions, and then the rest are math. I say roughly because there are some tests where it's like, wow, this is really good, juicy material, and they've got really good questions, and it may be 55 questions with 5 math. I've had some tests where it's like, okay, well, this is a pretty basic test. There are roughly 50 questions and then the rest are math. So I say roughly 50-ish, and then like I said, the remainder of the questions are going to be math. It is proctored and it's also 2 hours long. That will give you 120 minutes. That gives you roughly 2 minutes per question. I find that most students usually get done with them within about an hour and a half. Don't feel bad if it takes you the 2 hours. I've had some students that literally wait till, all the way up to the minute because they're really reviewing stuff, and that's fine too. I mean, don't worry about it. All right, so questions, I want you to read them slowly. I want you to read them carefully. I will tell you that when I do test review individually, I have found that students are like, oh, I read that wrong. Well, how fast are you reading them? I want you to read them slowly and carefully. What is it asking you? What information did I tell you? You'll find that some of my questions, I actually give you all the details of a disease process. You're like, oh, that sounds like a UTI. And then I tell you in the question, Grandma has a UTI. And you're like, oh, well, I knew that. I'm telling you all the information because I know you know it. What I want to know is what are you going to do about it? What interventions? What will you see? What labs will you look at? You have to read what I'm asking you. I will find that also some of you will either go down the rabbit hole. Sometimes that works, sometimes it doesn't. I will also find that people are going to be like, but you didn't give me this information. Sometimes that information is implied, and I'll give you a example of that next. But read the question slowly, read them carefully. What is the question asking you? What is the question implying? Perfect example. The nurse is caring for a patient with a small bowel obstruction. After the nurse places an NG tube and connects the tubing to moderate intermittent wall suction, they receive the following orders. The patient is NPO except for their meds. They can have digoxin at 125 mics, they can have that which is by mouth every day, metoprolol 25 milligrams PO every day, Coumadin 2 milligrams by mouth every day, and Plavix 75 milligrams POQ day. The nurse would question which medication or medications. If you reread this question, I told you the patient has a small bowel obstruction, I told you they have an NG tube, and I told you that they're actually on suction. It makes sense that if I actually give a patient pills with an NG tube that's actually sucking what's in their stomach out, if I give them the pills, it's going to suck the pills out. So you learn when we do the NG and GI that you actually place an NG tube. If you're going to give pills, you turn off the suction, you give them the pills, you wait 30 minutes for the pill to dissolve, to get into their system, for it to work. You turn the suction back on and it sucks out the stomach content, not sucking out the medication. That's what's implied. And it's implied because that's true. That's something you will actually learn. What I'm questioning is, these meds I'm allowed to actually give, but what would I actually question as far as why would I still give this patient the med? Now, these meds I know come from block 2. I know you learned them. All I'm doing is taking the information that you had and bringing it forward. I would question the Coumadin and the Plavix. And the reason why is because the actual Coumadin and Plavix being a blood thinner, if this patient, for having a small bowel obstruction, has to have surgery, I have to wait 3 days for the Coumadin to wear off for this patient to be able to have surgery. And if it becomes emergent, I have to do a lot of other interventions to be able to combat or to change that Coumadin or that INR level for them to have the surgery. Metoprolol, that's okay because that's just fixing their blood pressure. Digoxin and metoprolol, that's okay because one's fixing their heart rate and one's fixing their blood pressure. The nurse should hold all meds? Well, you could, but the patient actually is allowed to have the meds. So the actual answer is Coumadin and Plavix. All I've done is I've actually taken new information that you had or have, and I'm taking the old information that you had from block 2, pushing them together and making you think a little bit differently, a little more critically, a little more in depth. All right, so higher level concepts. Again, I've talked about this before. 80-year-old female admitted with a UTI with a history of AFib, COPD, and diabetes type 2. That's higher level of thinking. You will get this from me. You're going to go to block 4. Sarah's going to do the same thing. All we're doing is take what we know that you've been taught and just bring it forward. So when you take your NCLEX is not going to say, well, grandma has a UTI, what are you going to do? NCLEX is going to go, hey, you've had 4 semesters of nursing. You've learned all these disease processes. Now let's put them together and see if you can critically think about what the patient's there for now, what they have had in the past, and how that affects them, and do I have to change my interventions? All right, so testing center. If you actually use the testing center for your tests, I need to know. Sometimes I get some stuff from the testing center, sometimes I don't. Sometimes I get things and things are buried. So I need you to actually tell me, hey, I am a testing center student, and remind me so that way I know, that way I got the information. Waiting until the day before the test to go, hey, by the way, I'm a testing student or testing center student doesn't help me. For those of you who do work in the hospital or even work anywhere really, your boss doesn't want to know the day before that something is due tomorrow. Tell me as soon as you know so that way I'm able to actually fix it and give me time to prepare for it. So life lesson, if you're going to take the test in the testing center, let me know as soon as possible so that way I can plan ahead. Same thing with lectures, same thing with labs, same thing with clinical. I know that things come up, but telling me the day before that, hey, I got to work tomorrow, and I knew 2 weeks ago, and I couldn't really fix it, that doesn't help me, and I can't help you. But give me several weeks in advance, several days in advance. Give me time, and I can probably figure out something, and we can fix that problem together. All right, so don't forget, the final is Med-Surg and OB. We believe that we're probably going to have 2 tests. Or 2 separate tests, but they combined will make 125 points. Med-Surg is usually 66 and 13 for math, and the rest is OB. Because of the fact that the semester has been shifted, I think the actual final date may be shifted also, and that also means that the HESI may have been shifted. So for the most part, hang tight. Again, as things come up and the more information I have, the more I'll be able to actually give that information to you. All right, so VSIMs. VSIMs is part of your clinical replacement day. I know that you guys have done VSIMs in the past. We will definitely do them for Block 3 for the Med-Surg, and the code for those of you who are now with me in Med-Surg that came from OB, groups A, B, C, and what used to be X, you all use the same code. It's 1649, C as in cat, 0, B as in boy. The day of clinical replacement, your clinical instructor, whether it's Darren, myself, or Cindy, will say, okay, so today we're going to do VSIMs. Here's the patient we're going to do. We will probably do whatever case study, med math, medication concept sheets, whatever you want to call it. We'll do those first, and usually that afternoon, we then do the VSIMs. And you also do DocuCare. So make sure that you actually write down information as you're doing the VSIM. So when you do DocuCare, you actually can go, okay, so here's the labs, here's what I saw, here's interventions, here's this, here's this, and this. Because once you're done and you've passed the VSIMs, you don't want to have to go back and not pass it. But you have to do DocuCare, and I'll give you codes to that in a minute. But make sure that you take notes as you do the VSIMs, because that would just make your DocuCare so much easier, so much better, and just be better for everybody. So DocuCare, these are actually split up into individual groups. So if you are in group A, it is F0944, E as in Edward, D as in dog. For group B, it's 4, A as in apple, 846, B as in boy, 59. And for group C, it's D as in dog, F as in Frank, C as in cat, 1, F as in Frank, 341. And again, group X no longer exists. And clinical and DocuCare. So I talked about this before. Not only are you going to have clinical replacement, which is online, it's virtual. You do not have to wear your scrubs. You can if you want to, but you don't have to. But as far as clinical, you all will have one clinical day. Make sure you show up in your scrubs. Make sure you have your stethoscope. Make sure you have paper, pen, snacks, whatever you need. I want you to show up as if you're a nurse. You're going to be there for 12 hours. You're going to literally be working next to, whether it's the nurse you're with, whether it's me. I'm going to teach you how to be in the clinical setting. But prepare for the day. Like I said, make sure you have your stethoscope and your scrubs. I've had a student show up and like, "Where's your stethoscope?" And they're like, "Oh, I forgot it at home." Well, that doesn't do you any good. I don't leave my stethoscope at home. So make sure you have your scrubs, stethoscopes, your pen, snacks, and whether you're at Baywood or Desert, see here, the cafeterias are actually not too bad. But don't bring your books, don't bring your laptop, don't bring anything that is, because I did this as a student. I take stuff to work, like, oh, maybe if I have a minute, I can sit down and read this chapter. Those are the days that are the busiest, and I never got to it. So it literally sat there in a corner and did me no good. So don't bring stuff based on thinking you'll have time, because you just probably won't. DocuCare, you will do one patient, one a week. For you guys, you have one clinical day, so you will pick one of them. You will actually do a DocuCare, and I gave you the doctor codes. Usually it's due based on your clinical instructor, which I think you all have me. So we'll figure out a day based on it working. All right, so this is block 3. So things that you will need to know. Definitely IV piggybacks and IV pushes. It's impossible for you to know every med, how fast you push it, how long it's going to take to work, but I want you to know those things. So when I ask you, hey, what would you give grandma for pain? And you're like, oh, I know, I'll give her morphine. Great. How fast will you push it? And you're like, well, I don't know. I think 2 to 3 minutes. Well, thinking doesn't help. That's when you go to your Google, that's when you go to your book, that's when you go to Lippincott, that's where you go to your resources, and it will tell you, push this med over this amount of time. And I'll say, how long do you expect it to work? And you're like, well, I don't know. Well, the book will tell you. Something will tell you. They've done research. They know when it's supposed to work. It's good to know when it works, because of the fact that when grandma says, hey, I'm in pain, and you're like, I'm going to give you morphine. She's like, I'm in so much pain. When is this going to work? It's going to work immediately. Give it a couple seconds. It will start to work. By the time I've gotten done taking the 2 minutes to push it, so grandma, do you feel better? Oh my God, I feel wonderful. It's because I knew that it was going to take that long. I know that Zofran takes 20 minutes for it to work. Your patient who is wanting to throw their guts up, who can't, who's nauseous and needs something, you give them Zofran and they're like, when's this going to work? And you're like, oh, it should work immediately. And you leave the room and they're laying there looking at the clock going, well, it's not working. I know it takes 20 minutes. The book tells me it takes 20 minutes. Tell your patient it takes 20 minutes. So when you leave the room, they're able to go, okay, in 20 minutes, I'm going to feel better. I'm staring at the clock. I know 20 minutes has passed. Oh, yes, I do feel better. So I want you to know, what is it used for? How long will it take to actually work? How long can you take to push it? What are you expecting to accomplish? What side effects are? What adverse reactions are going to happen? If I give I've given Dilaudid to people who I thought was actually going to help them, and I had a guy actually code from it. And it's not like a, oops, I'm sorry, I didn't know. It's that wasn't expected, but critically thinking, I knew I had to do something different. So those are what I want you to know is those things. And whether it's antibiotics or whether it's IV pushes, this is block 3. This is the fun time, because let me tell you, when I went through block 1 and block 2, I was like, oh, this is boring. Big deal. I could pass out pills all day. But when it was time for block 3, it's like, oh, I get to push stuff all day. That was the fun stuff. All right, so letter of recommendation. I have no problem doing a letter of recommendations, especially for those of you who will be going into whether it's extern positions or when you do graduate. I do letter of recommendations based on knowing who you are. If you send me an email in 6 months from now and I have no idea who you are because you're the quiet person who never said 2 words during a lecture, or I had to pull stuff out of you, if I don't remember you, you don't get a letter. But if you're the one, oh yeah, I remember you, and you were really good. I have to be able to give you a letter of saying you're great and you're good for a job when I know that you probably are good for it. Plus, you have to pass the class. I've had some students that like literally are like, hey, I want to be an extern at this hospital, and I'm like, you didn't even pass my class. Like, you might clinically know how to do stuff, but do you know how to critically think? I was an aide before I was a nurse, and let me tell you, being an aide made me very efficient, made me very organized, and allowed me to monitor my time. I usually had like 17 patients to do vitals on, AccuChecks, and a whole bunch of other things, and wiping butts and changing sheets and all that stuff. You have to be able to learn how to be able to balance all that stuff. That is nursing. So when you when you go from me to block 4, yes, you may be book smart, but can you really go in the room and actually do all those things? Do you know why you're doing them? Is there, that's the whole point of the letter of the recommendation, is I want you to be able to, be good at what you're going to do. And I work for Honor Health. I've had several students who I actually work with as whether it's aides or I've actually gotten jobs as nurses. I'm like, hey, can I have a letter of recommendation? Yeah, you're really good. You were really somebody I knew that I'd want to work with. So I don't make it difficult, but in the same sense too, everybody and their brother will send me one, and it's like, can't remember you, so sorry. All right, so about me, I think I mentioned this before. I was a phlebotomist before I was a nurse. I love sticking. I think the phlebotomy is the most fun thing in the entire world, but unfortunately, it pays crappy. So I couldn't live off of that forever, and so I went from phlebotomy to being a CNA, and that was during nursing school. I worked during nursing school. I went to school Monday through Thursday, and I worked Friday, Saturday, and Sunday. I had to balance both. I had bills to pay. I had to actually do both. I'm not saying that that's for everybody, but I know how it is to be able to work and do school at the same time. I will give you empathy because I know how it is, and especially in the times of COVID and the fact that the school's off by a week. I know that this is a stressful time, and I know that there's things that are out of your control. And I've received some of your emails saying, "Hey, I thought the tests were these days, but now they've changed, and I have to let work know." I completely get that, but in the same sense too, there are some times where it's like, "Well, I have to work." Well, I'm sorry, but you have to be able to make me somewhat of a priority. Lecture and labs are on Mondays and Tuesdays, clinicals are on Wednesdays, and your live clinical and banners are, I think, Thursdays or Fridays. I have to be able to do something, and you have to work with me. I will adjust things as they come based on what you have that is unfixable, but your lack of being able to change things at the last minute doesn't mean that I have to be able to change that. I will do my best to try, but in the same sense too, I know how it is to be able to go to school and work at the same time. But I also was between being a phlebotomist, maybe a better IV sticker. I can tell you that being a CNA and an LPN, by the time I actually graduated, I've like, show me something I haven't done before. Because I just kind of worked my way up. Being a PIC nurse, I did that for about a year, and I liked it, but it's kind of a retirement job. But I liked it, and now we have Lines team, so I don't really have PIC nurses anymore. So, but I think that's pretty much about it. My word of advice to you: keep it simple. I know that you want to read. I know you want to know all the information. I know you want to be like, oh, I know you're smart. I know you study. I know you guys do all these things. You give me no reason to believe that you don't. But in the same sense, too, giving me the, textbook book version of an answer, sometimes you lose me. When you do your studying or do your concept maps, think about what you would do with grandma. Walking into her room and educating her on things at a level that she can understand. I want you to think that way because going into grandma's room, giving her textbook answers at a level where she's like, I have no idea what you're talking about, or you're using words that she can't really grasp, or they're too big. She's going to go, yeah, I understand. And then she's going to go home and not understand anything you said. So keep it simple. Keep your concept maps basic. What do you see? What interventions are you doing? What diagnostic studies are you doing to prove either whether they have the disease, whether you need to change something? And like I said, just keeping it simple. Because remember, I'm simple and stupid. So, and I'll tell you that about hard times during lecture. All right, so I think that I have talked myself to death. It was about an hour long. If you have any questions, let me know. I am going to post this in a couple minutes, and I think that's about it. So far, email still works. So if you have questions, email me. I will respond. If you don't get an email back, I most likely didn't get it based on the system being shut down. But I'm pretty good. I mean, I'm usually tethered to my phone, and I usually respond to things as quickly as possible. So anyway, so that is your orientation, and I will see you guys next Monday where we will do med math. Med math actually came from your Henke's med math book. I believe it is roughly the 200, like 270 something. But those packets came from that book. The answers are actually in it, and we'll go a little more in depth on Monday for that. So, all right, let me know if you guys need anything, and I will see you guys on Monday.